My mum's Annie and she's 90 years old now. Before moving into the home, my mum's always been a very independent, strong, determined lady. She had to be. My dad was in the RAF, so she looked after 7 of us on her own for a long, long time. She was always very strong. She worked a lot, she cooked, she sewed, she did everything. But we noticed that her short-term memory was becoming quite bad. Time went on, her memory became worse, so we got a care agency in to enable her to stay at home and keep her independent. They would go in and make sure she'd had her medication, make sure she'd had some food and drink. This was supported by us as well, as much as we could. As time went on, it became very clear that this actually wasn't enough, and there was a bit of a crisis really, and Mum became quite unsafe at home. So the decision was made that we really needed to start looking at care homes. We looked at CQC reports, we spoke to professionals, we visited homes unannounced. We also did a little bit more homework as well. We looked at what support the homes would get from the local community, things such as GPs, whether there was an older person specialist nurse attached, whether there was access to other services such as physio, occupational therapy that Mum might need. And when we went to the home, we were looking for the visibility of staff. The actual day that we moved Mum to the home was very upsetting for everybody, but actually our Mum made it quite easy for us in a way. We spoke to her, we were very honest with her, and we said that we were all concerned about our safety and that we needed to think about moving her into a care home. And she just said, right, that's it then, let's go, put a coat on, get me there, because if we wait any longer I won't go.
I'm responsible for making sure that the residents receive good standards of care and that the staff within the home are suitably trained to be able to provide that care. We do have a weekly ward round. The GPs visit each Monday morning to review the client's care. The staff usually have a list of clients, what conditions they've actually got, the problems that they actually have, so that we can discuss and then formulate a treatment plan or an action plan that provides them with the care that they actually require.
We do weekly ward rounds in the care homes, see anybody who's unwell, anybody who the staff are concerned about, or anyone who would like to see the GP. And within that I do my own comprehensive geriatric assessments, where I'm able to assess the patient proactively to enable me to identify any problems or issues the patient might have and make sure that they're in receipt of care that is relevant to their needs. So I always include the patient, and with their consent, their relatives, and also the care home staff or nursing staff in the care homes, so that I'm able to complete a full picture of what's going on with the patient. One of the challenges of care home work is that a lot of our clients, our patients, have dementia. In respect of that, we would try and involve families where possible. If patients don't have any family, that we would involve an independent mental capacity advisor to help inform our decision and just make sure that really we're acting in the best interests of the patient.
Before we had the CAMS programme, I was very much working in isolation, and now I have the huge benefit of having a team of the specialist care home support team around me, which includes a link nurse who I meet with every week to do the ward round. And the big advantage of that is the link nurse can do a lot of fact finding behind the scenes. She can pop into the hospital if necessary and gather more information from the ward. And it means that when I arrive in the care home, I'm not just meeting patients for the first time without any information. We also have a background team behind here, which includes a pharmacist and a palliative care nurse, and we have access to occupational therapy as well. And having that huge team means we can make referrals very easily and deliver much higher quality care to the residents in the care home.
Start by going in and doing a baseline visit and getting a feel of the home, the policies and the procedures, the type of medication systems they use, check with the pharmacy and see what problems they have, or if any, with the care home. Wherever possible, I'd go and speak to the patient and ask them what their view was on the medications they were taking. All in all, looking at what's best for the patient.
I fit into the enhanced care model that we provide by means of I attend the weekly virtual ward round along with all the older persons nurse specialists every week, and if they identify issues at the care home MDT, care home ward round within the care home, they'll bring those to the virtual ward and we can discuss those issues. Obviously that meeting happens once a week, so that's quite quick access, but in between those times they can ring me, they can email me, contact me, and we can discuss issues that way. What that means is that they've really got quite quick access to specialist advice and input on their patients within the care homes. Some of these people I might just offer bits of advice and ask them to try something and feed back to me the following week or so, whereas a number of them obviously I might want to come and see for myself, so I'll either arrange to go out at a time convenient to the home and the patient, or quite often actually I'll try and go along and join both the GP and the nurse specialist during their care home ward round, so we can do some really sort of hands-on co-working with some of those individuals.
I'm a consultant community geriatrician. I work part-time in a job share with Dr. Maddock. We provide community geriatric input for Gateshead, predominantly by providing a specialist opinion to the virtual ward. Our main role, once we receive a referral, is initially to look at the hospital notes and try and glean as much information about the patient as possible that may have not been available to the GP or the specialist nurses in the past. We can sometimes then make a management plan with the specialist nurses on that information without going to see the patient, but for other more complex patients we would then go and visit them in the community.
The comprehensive geriatric assessment also informs part of my emergency healthcare plan. This is a document that we can complete and share with our out-of-hours colleagues to identify and record patients' future care wishes.
Gateshead Urgent Care Team is a reactive service, a nurse-led service that sees patients within the Gateshead area. Patients that we see within the nursing homes are frail elderly patients. Those frail elderly patients often present with functional changes rather than specific symptoms.
An example of how we've prevented a hospital admission is if a patient is in a nursing home or residential home and they have cellulitis and they need some IV antibiotics. They wouldn't at one time have had to go into hospital for this treatment, but we now provide that treatment at home, which means the patient can stay at home and be cared for.
When we have a detailed emergency health care plan in place, it really assists the team as we can then assess and we can also treat the patients based on the patient's own wishes, the family's wishes, in conjunction with the GP.
Today my mum isn't so grand. She's being diagnosed having a chest infection, but that's being picked up really quickly today by the carers who spoke to the nurses here, who've then spoke to the GP, and she's actually started antibiotics an hour ago. So that's being picked up really quickly in this particular care home.
If I was going to give you advice as to how to set up a regular care home round, there's quite a few learning points. I would say that the first thing that you would discover is there's a massive unmet need in care homes, and you will realise that the care you were delivering before really was just, it was not enough and was maybe a drop in the ocean as to what was actually required. So there's actually a very steep learning curve in that you probably find that you're doing a lot more work initially because you realise there's so much more that needs to be done. But once you get past that and you become more organised and you get to know the residents in a much more comprehensive and holistic way, then life becomes that much easier and you benefit from the quality of care that you're offering. It gives you a lot more job satisfaction because you know that you're actually delivering the care that's required to some very vulnerable residents. So my best advice is to be prepared for a lot of work in the initial stages, but you will most definitely reap the rewards further down the line.
The specialist nurses are vitally important to the whole whole project. And also the old age psychiatry input as well as the medical input is also vitally important, so we can provide a holistic patient assessment from the MDT and plan really good care for patients in the future.
For me, I think the massive advantage of this way of working is that we can address both the physical and mental health needs of this group of people who have very, very complex comorbidities, and all those physical and mental health needs are quite enmeshed, and the fact that we're able to address those together at the same time and think about them holistically, and to access both the primary care and secondary care input to be able to do that all together, I think really helps us provide the best possible service we can for this group of people with really complex needs.
We know that there's regular support here from the GP. He does regular rounds. He also works very closely with an older person specialist nurse who's absolutely great. We also have had support from the geriatricians in the community and also psychiatry that mums needed. We've also had support in here from chiropody and from physio and occupational therapy here for mum. So at the moment we're very happy with the care that she has here.